Okay, thank you very much for the invitation. It's nice to be among good friends. I'm going to lighten up a little bit the conversation, and I'm going to stimulate the conversation in terms of the quality of life after breast reconstruction. The truth is that even if the numbers that you can see in the US about breast reconstruction, they're quite significant, still they're lagging behind. There's still a lot of misinformation about if breast reconstruction is necessary. And there are a lot of, actually, starting with New York State, now there are a lot of states that actually they consider malpractice for the surgeon who deals with breast cancer not to inform the patient that he has the option of breast reconstruction. So is breast reconstruction a cosmetic or a reconstructive surgery? It's not a cosmetic surgery, but at the same time, it is a cosmetic surgery. But the truth is that it's an integral part of the treatment. And for sure, as it was first mentioned in 1997 with the first study related to outcomes and quality of life, it reduces psychological and morbidity and improves the quality of life of the patient. So we know for sure, empirically, that reconstruction improves self-image, self-confidence, quality of life. The social and emotional participation of the patient is much better, and obviously the patient is more functional since she feels more complete. Now, the first clinical evidence in terms of how breast reconstruction improves all of the above was shown in papers even from the 60s, from the 2003, I'm sorry. But more and more studies are keep evolving, and this is because we started using what we call the patient-reported outcome measure. So there was a need to generate questions, and in order to pass them on to patients, and before and after surgery, and actually measure how the patient feels about certain aspects of their lives before and after surgery related to the breast disease and the breast reconstruction, and in order to help the breast reconstruction surgeon and the breast surgeon actually choose among the various options, like the ones that Dr. Martu mentioned before, what to use for the reconstruction. So there are currently these are the four most commonly used ones: the breast Q, breast questionnaire, and I'm going to analyze a little bit of them later. The BRACON, the EMBROS, and the European one. They're all developed in order to measure quality of life domains, and I'll explain later what that means, in order to affect the breast reconstruction in a better way. Now, the breast Q, which was developed by Memorial Sloan Kettering, the place where my friend Dimitri was, and actually measures 3 quality of life domains: physical, psychosocial, and sexual well-being, and 3 satisfaction domains: 1 related to the breast, 1 to the overall outcome, and 1 to the process of the care. This is the most widely used one. In order for somebody like a breast reconstruction surgeon to use it and pass it on to the patient, you have to actually register with the people that developed that in Memorial Sloan Kettering, and because it involves obviously a lot of work for them, it's kind of like a copyright thing. The good thing about it, you can validate the results among different populations and the whole world, and it's very international based. Now, the BRACON, which is kind of like a similar test, assesses 8 domains, as you can see in the slide: self-image, arm concerns, intimacy, satisfaction, overall recovery, self-consciousness, expectation, and appearance. And there are also 2 additional domains if the patient had nipple reconstruction or not, and if the procedure was done from the abdomen or not. And the good thing with the BRACON is kind of like interchangeable with the breast Q in terms of they validate, the one validates the results of the other one. Now, the EMBROS was pretty much the one that was used first and generated out of Michigan. The only problem with that, it doesn't really follow different international patterns in terms of care and reconstruction, and it's only limited to the tram surgery and implant techniques only. And the European one is currently evolving. It's quite complicated, and currently it's under the phase 3 of development of the whole study, so it's not very widely used right now. Now, an example of what the breast Q is. For instance, there is a preoperative example of a question that they ask the patient, with your breast in mind, in the past week, how satisfied or dissatisfied you have been. And they have to grade it from 1 to 4, and they have, as you can see here, 4 sub-questions, and that goes on and on. There's another question, like for instance, with your breast in mind, in the past week, how often do you felt, for instance, confident in a social setting, emotional, able to do things that you want to do, and that goes on, and that gives you a score that after answering all the questions, you go to a certain guide, and you can classify the patient according to its needs in terms of quality of life, what they want and what they expect from the surgery. Another question, for instance, in the past week, how often have they experienced pain in the muscle, difficulty living or moving the arms? And you can compare that, another preoperative questions here in terms of sexuality, which obviously is very, very important. And you can compare that with postoperative questions and add postoperative questions in terms of, again, how confident they are in a social meeting after the surgery, how emotional healthy they are, how self-confident they are, how feminine they feel with their clothes on. And you can compare that with before the surgery and make adjustments to your care. Actually, συγγνώμη, ο κύριος με τα τεχνικά λίγο, μπορείτε να μου βάλετε το file που είχαμε δείξει για να σας δείξω ακριβώς πώς είναι, το questionnaire. This is exactly how the questionnaire looks like. It's a PDF file, so it has, it's 33 actual pages from the short version. There's a longer version also that has even more questions. And this is, it's a very practical way for the patient to fill it up and give it to the surgeon. They can email it, so they don't have to fill it right there in the office. And it's very, very, very useful. And actually, I started using that about 2 years ago, and it helps me a lot in choosing many types of surgery. Μπορούμε να πάμε πίσω στο presentation. So, by using, so with using all these types of questionnaires, some studies started to evolve in order to decide the quality of life and actually comparing different methods of reconstruction. So this group from Sweden actually, and that was published in 2017 in the PRS, it's quite a recent article. They studied about 685 people. About 2/3 of them responded to the questionnaire, and they compared different types of reconstruction, like the DIEP, the latissimus flap, the latissimus flap, or the expanders. And just to lighten up with a few and remind you a few cases, like for instance a case like with a free tram after radiation therapy. Another free tram with a skin-sparing mastectomy case, right immediate DIEP reconstruction with skin-sparing mastectomy before and after, a case with implant reconstruction, and a case with, actually it's not an S-gap, it's an I-gap, that's a misnomer, in a patient that wanted also a lifting of the butt at the same time. So based on these questionnaires, this study, for instance, they studied how the quality of life in patients with DIEP or implants was affected. And as you can see here, in the Swedish study at least, 52% of the patients that had DIEP were very satisfied from this type of surgery, whereas the great satisfaction for the implant cases was about 20%. So you can have an idea in a certain population like that, in the Swedish population, that in Sweden perhaps they prefer the outcome from DIEP flaps. Perhaps in the United States that could be the other way around. For instance here, with a questionnaire that's called the SF-36, which is called the short questionnaire actually, they decided to actually compare the 4 different types of reconstruction that I mentioned before, and pretty much they found that among all these questions like physical functioning, role, the bodily pain, the general health, social functioning. There was no different among different types of reconstruction. The only statistically significant difference was in how their overall vitality was after the surgery. They found out that with the green, which is the latissimus dorsi, the expander, they had greater vitality. So perhaps that's the easiest surgery for greater vitality in that certain group of patients. And they also started in another study with 930 Swedish patients that the same group did later on. They found that statistically it was better overall health with they compared normal population with patients that they have breast reconstruction, and actually, except from the general health and the vitality that I mentioned before, and the physical functioning, that they had statistically significant results between the women with breast reconstruction and the women without breast reconstruction. All the other parameters that they measured, like for instance the bodily pain or the mental health or the physical component, there was no much statistical difference between those two groups. And that goes on and on by measuring more parameters, and I'm not going to tire you with the statistics, but as a conclusion, at least in this country, as I mentioned before, people that had the EP flaps were more satisfied than the other three groups. And so this is perhaps for the surgeons that operate in that area. They know that based on their patient population, they should probably offer more of this type of surgery in order to have happy patients. And there's another study by the University of Toronto, by the group of the Department of Plastic Surgery, that they actually even measured the anxiety and the depression depending on the different types of reconstruction, especially if it was delayed versus immediate. And if you can see, okay, and if you can see the yellow, which is the immediate line, immediate reconstruction, and the green, which is the delayed reconstruction, you can see that at least at the 12-month period that the people had to wait in order to have reconstruction, they had more anxiety and more depression. So that's a case, perhaps, in order to, in selected patients, to offer the immediate reconstruction. Again, in the same group, they measured the body image as it was perceived by the patient, and they found out that, as you can see, the red line is the delayed reconstruction, and the blue line is the immediate reconstruction patients, that between around the 6-month period, the people that they had immediate reconstruction, they felt much better from the people that they had delayed reconstruction. So that's another case to make that perhaps you should be more informative and inform the patients that they can have, in certain cases, immediate reconstruction for pure psychological reasons. I'm not going to go through that slide, but essentially it gives you more statistics about how this outcome analysis in terms of satisfaction with the breast, with the well-being, your sexual behavior and physical well-being can be affected from different types of surgery. Even now, there are questionnaires that they're and research studies that they're done through the Facebook, and they have all these questions that they're generated actually from the patients. This is the feedback that they give to the doctors. And that tells us the power of the social media, even in doing research these days. And from that study, the Facebook study that was conducted, again, it was found that people that had the EP flaps were more happy than the patients that had implants. That's something to consider. And the last study I would like to show, again from Toronto, they used these questionnaires in order to answer 5 different questions. The one is the timing of breast reconstruction, and they found out that even both immediate and delayed breast reconstruction patients experience increased satisfaction and quality of life after the reconstruction, and that satisfaction was similar. However, patients undergoing immediate breast reconstruction may be protected from a period of decreased satisfaction and quality of life, so that's another thing to consider. They answered also the question, autologous versus implant reconstruction, and most of the patients responded they would prefer autologous reconstruction. They asked the question, for instance, what type of autologous reconstruction is better for them, and there was no definite conclusion in terms of what type of autologous, Dieppe versus Tram versus Latissimus or whatever else you can use. They also asked a question, what type of implant was better for them after the surgery, and obviously most of them responded with the silicone and type of implant, and I say that because here in Europe we use mainly silicone implants, but in the United States they still use a lot of saline-based implants for reconstruction. And obviously people that had reconstruction after nipple-sparing mastectomy were much more happy compared to people that have just skin-sparing mastectomies. In general, breast reconstruction is a demanding surgery for both the patient and the plastic surgeon, and needs special training and dedication for this type of surgeries. Thank you very much.